Before we begin, I thought it would be helpful to provide a bit of historical context of where we are. So it's 1945, the Second World War comes to an end, in Europe at least, and Germany is divided into 4 occupation zones. The areas here in green, blue, and orange are then united by the capitalist powers to become the Federal Republic of Germany, or as it's commonly known, Western Germany. And then 5 months later, in response to this, in the red zone here, it becomes the German Democratic Republic, or East Germany. And so we have these 2 states then, 2 German states, and it's interesting because we then have 2 very different paths that are followed. In the West, we have restoration, not only of monopoly capitalism, but also of traditional medical practices. And then in the East, we have a new beginning. We have a gradual transition to socialized property relations, and this serves as the basis for a revolution in the health system, both in terms of care and also in the working conditions. And it's this approach in the East that we looked at in our publication. This new beginning in the East is led by anti-fascists, mostly communists and social democrats, who are emerging out of the Nazi concentration camps, or they're returning from exile. And they basically find themselves in a situation that's catastrophic. Germany, the German fascism had propagated this idea of total war until the very end. So throughout Eastern Europe, you just have a catastrophic health conditions. Hospitals and clinics have been destroyed. There's no access to medicine. Diseases like typhus and dysentery are spreading uncontrollably. And on top of that, in Germany, you have the problem that about 45% of doctors had been Nazi Party members. Many of them had even been involved in euthanasia and other atrocities in the concentration camps. So you were confronted with the question, what do you do with these doctors? Many of them actually end up fleeing the Soviet occupation zone, and they go to the West because they know they'll be treated more leniently there. And so from the very beginning, you have a very large shortage of doctors in the East. Now, to tackle this situation, the East German health officials basically set out to construct a new system. And they did so by drawing on progressive traditions, the first of which was what's called the field of social medicine, or public health, as it's usually called today. And it sort of emerged in the mid-19th century, and then it's taken up by the labor movement after that. But what social medicine does is it looks at the interaction between people's health and their social conditions. So in other words, what we call the social determinants of health. So working conditions, housing, nutrition, education, our social relationships, our free time, all of these factors, they basically form the basis upon which our physical and mental health develops. So this was the first tradition, and the second tradition were the experiences from the Soviet Union, where health officials had actually put social medicine into practice through a unitary and centralized national healthcare system. And officials in East Germany, they also recognized that it would be necessary to separate people's medical needs from private economic interests. So just to provide an example of this, if we look at the outpatient sector, this is where care is administered outside of the hospital system. So like if you go to your general practitioner for primary care, getting a blood test or having an examination, well, in the capitalist outpatient sector, it's usually done by self-employed doctors in private practices. They're working in their own practice, basically. And the problem here is that they're financially dependent on sick people coming to them for treatment. That's how they charge insurance companies, and that's how they generate their income. So these self-employed doctors are essentially incentivized not to prevent disease, but to treat symptoms after they've already manifested. And this is not something that the GDR discovered. This was a fact that had been discussed by progressive health experts long before the GDR was founded. Also, in the League of Nations following the First World War, this had also been a topic. But the problem was that conservative physicians' associations, who had an economic interest in the old model, they opposed all attempts to modernize outpatient care. And so this was the basic task that then the East German health officials set themselves, was separating healthcare from private economic interests. So how was this done? Well, basically it required the nationalization of healthcare institutions and the guaranteed right to healthcare. So in the socialist states, free medical treatment was to be provided through a unitary healthcare and insurance system. So all health institutions, from hospitals, clinics, pharmacies, research centers, and so on, they were all managed and planned by different levels of government. As you can see in this graph here, which shows the structure of the health system at the regional or municipal level, it's not fragmented between publicly funded services on one hand and privately organized care facilities on the other, as many of us know from capitalist systems today. But it's a unified system in which all these health facilities cooperate, and they're led by the Ministry of Health and its departments. And by linking these various institutions together in this way, it became possible in the socialist states to integrate preventive, therapeutic, and aftercare measures, something that's really greatly hindered by the fragmented model of outpatient care where, for example, you have little contact between doctors who are administering therapeutic care and those that are administering aftercare, or the pharmacists that are providing medication, and so on. They're all fragmented in the capitalist system. So with this unitary approach, emphasis in East Germany could now be placed on prophylaxis, which is the medical approach that tries to prevent disease before it manifests, instead of just focusing on treating symptoms. And by pairing prophylaxis with social medicine, it becomes possible to approach health policy from a socio-political perspective. So how are working conditions, housing, social relationships, and so on, how are they affecting our health? And once we've established this link, what do we do about it? Well, the key development in the socialist states is that you have this gradual creation of socialist property relations. And this was crucial because it meant that all these social determinants of health could now be managed by the state and its decision-making structures. So you have through this large network of public outpatient facilities that are operating in all areas of society, you had a way of systematically investigating and tackling everyday health risks. In the neighborhood, the schools, the universities, the workplace, all of these institutions are basically integrated into the healthcare system. And so with these two guiding principles, prevention and social medicine, the protection of health comes to be understood not as an individual responsibility, but as a social responsibility. So I've just taken a few pictures here to provide some examples from the left to the right. And on the left, we have the workplace, where public health officials would carry out inspections to make sure that working conditions are monitored and that workers are receiving care that's really tailored specifically to the relevant health risks, like chemical exposure or heavy lifting and so on. In the middle, we then have residential areas where health inspectors are tied to the local outpatient facilities, and they're measuring noise or air pollution in the neighborhood and monitoring health in daily life. And in kindergartens and schools, you have then medical checkups and vaccinations carried out directly by the pediatricians on site. So it's no longer left to parents to organize and keep track of various appointments for their children. And so in this way, we have to think of socialist healthcare as kind of a holistic and comprehensive system that's integrated into all areas of society. And it would accompany people throughout their life, from kindergarten through the school, through the workplace, and all the way into the neighborhood where people would retire. And so what's the infrastructure that supports this socialist approach to healthcare? It's a massive outpatient network primarily. And we can't go into each of the aspects here, but I think it's worth highlighting the polyclinic because it kind of epitomizes or embodies the socialist approach. Now, the polyclinic was basically a facility in which multiple medical specialties are collaborating under one roof. As you can see in this cross-section example here, there are several core departments like general medicine, pediatrics, gynecology, internal and oral medicine, and a surgery department. But polyclinics usually also then had other departments like laboratories for diagnostics, physiotherapy, medical imaging, and so on. And these polyclinics were to be sort of the central nodes in the wider outpatient network, which included smaller facilities and also mobile care units, such as like community nurse or mobile dental services that would then reach more remote rural areas. And the idea was that all these facilities were linked together to facilitate collaboration and mutual support amongst them. And so why is this polyclinic then designed to replace the traditional model of individual private practices? Well, it was recognized that this private practice model of outpatient care is outdated, and there were two reasons for this. First, as I already mentioned, the self-employed doctor in the private practice is economically interested in treatment, not in prevention. But secondly, there have also been advances in science that have greatly improved diagnostics and treatment capabilities. But in order to practice these new methods, you need access to the latest technology and expertise. So small individual practices that are scattered throughout cities, they just cannot house the diverse equipment and staff that's required by modern medicine. So patients end up then being referred to separate specialists or diagnostic centers, and this creates inefficiencies and also discrepancies in diagnoses. The thing about the polyclinic, though, is that all these specialists are in the same place. They work together on cases, and patients aren't referred to specialists that are then in different buildings. They don't have to travel to different buildings and wait for available appointments. They also don't have to keep track of their own records because the polyclinic has its own common filing system, which all the specialists can then access. And so there are a number of benefits to this approach. Firstly, there's the medical benefit of interdisciplinary collaboration on cases. And again, this facilitates this integration of prevention, therapy, aftercare, and rehabilitation. And this basically helps to minimize inpatient stays in hospitals and even prevent illness in the first place. Secondly, doctors also have access to laboratory and medical imaging services, and this helps to cut down on delays and bureaucracy. And then there are also the very practical advantages. For example, the polyclinic can extend its operating hours and continue to provide care even when individual doctors are sick or if they're on holiday. Private practices just struggle to do this. And linked to this idea is that this polyclinic system also allowed doctors to couple their normal consultation hours with on-site visits. This could then be used to provide more extensive care. So in East Germany, for example, pediatricians could conduct regular checkups in kindergarten while other doctors were looking after the walk-in consultations in the polyclinic. Now, the other crucial aspect of the polyclinic was that the public employment of its staff. So physicians, nurses, and assistants were employed by the state, and they were then freed from their financial dependencies on the sick. They enjoyed a secured position and a reasonable income, and this allowed them to focus first and foremost on prevention. But it's also worth noting that this transition from self-employment to public employment, it was a very gradual process that took place over the GDR's 40-year existence. This was also due to the fact that public employment was not embraced by all at the beginning. There was resistance, as I mentioned, there were these conservative physicians associations who'd already been systematically opposing calls for the polyclinic in the 1920s, and they continued to do so after the Second World War. And the East German policymakers, they went about this problem basically by trying to demonstrate the advantages of the public outpatient model. And so that meant sort of expanding the technical capabilities and the laboratories in the polyclinic over time, essentially creating sort of model projects which would make the benefits evident. And as you can see on this graph here, the transition didn't take place overnight. For many years, private practices continued to provide a large portion of outpatient care in East Germany. But over time, and with certain concessions to the physicians, it was possible to gradually win over medical professionals, especially as younger medical students who often had working class and peasant backgrounds came to see the benefits of fixed employment and socialist healthcare in general. Now, before I close, I just want to also emphasize that this transformation of healthcare in the GDR, it certainly wasn't a walk in the park. From its very early years, East Germany was confronted with several major challenges. Just to name a few, from the very beginning, Western sanctions were imposed on the East, and this greatly hindered the importation of modern medical technology and equipment. On top of this, East Germany was alone footing the bill for Germany's reparations to the Soviet Union because the capitalist powers suspended their payments in 1946, 1 year after the war ended. And then on top of this, the construction of socialism, which begins in 1952, is actually taking place with open borders to West Germany. And West Germany at this time was receiving, I think, about $1.5 billion through the Marshall Plan. And these open borders meant that those physicians who were reluctant to give up the private practice model or who were trying to escape the denazification process in the East, they could just leave. They could just go west. And actually, as a way of bleeding the GDR dry, West Germany would also, it was actively poaching East German doctors with the promise of higher salaries. So you had this massive brain drain of highly trained professionals whose education had been publicly funded in the East going westward. And it also has to be said that an additional challenge was the internal economic disparities in the GDR, particularly in the final decades when they struggled to balance out investment and consumption. And this meant that medical facilities also had to contend with outdated equipment or suboptimal structural conditions, and so on. And so all this meant that East Germany faced significant economic constraints, and not all of its health objectives could be achieved. We have to be honest about that. Compromises were made, for example, in the use of brown coal, which was the only native fuel source available to East Germany after the sanctions. But this brown coal was also a horrible air pollutant. Or working conditions in the factories, for example, they were also strained by the necessities of reindustrialization after the war. And so there had to be these kind of compromises between economic and health policies, and the officials had to weigh up the best way of going about it. So we can't think that eliminating profit from healthcare will solve all of our health problems. They won't just disappear overnight. But I think what we should recognize from this history is that social ownership and the centralized organization of health, industry, housing, and education, these are the preconditions for genuine policy debates. In other words, socialist planning is the framework for discussing and coordinating health objectives in relation to other social, economic, and political aims. So we're no longer just running around trying to fix market failures, as the liberal economists call it here, but we're actually consciously setting priorities and shaping society around people's needs, not profit. And this is exactly the approach that enables the GDR to progressively improve the health of the population over time, even in the context of limited economic resources and fierce competition with the capitalist West. So as you can see in these two final graphics here, infant mortality rates and doctors per 10,000 residents, nothing happens overnight. It's a gradual process, but from a much weaker post-war position, the GDR is able to reach levels that are on par with other industrialized states by 1989. And it had done so with a system that was run by and for the working people. So they proved that an alternative is possible. Now, this was just a brief overview of our second publication. The link is in the chat if you wanted to look at the full version. I just want to briefly also recommend that on our website we have an interview archive with filmed interviews that we do with those who actually built and sustained socialism in the GDR. It's a core component of our research, and it means that we don't have to rely merely on Western academia, which, as we know, is rather biased on these issues. So if you're looking for a good resource to hear about other aspects like occupational health care or vaccination strategies or maternity care, then I could definitely recommend checking out that archive on our website.